Hey everyone, welcome to Urgent Care Grand Rounds, brought to you by UC Maximus. I'm Britt Guest.
And I'm Scott Kovner. How are you doing today, Britt?
I'm doing awesome. We are here today to talk about all things urgent care. But before we dive into that, Scott, I know that you were recently at the Urgent Care Association conference with a good amount of our EMRAP team. How'd it go?
Yeah, we had a really great time. We met a whole bunch of new and awesome people. If you're joining us tonight for the first time, because maybe you got an email after the conference, welcome. We're really excited to have you. Hopefully you're going to have fun. We got to talk about a bunch of great topics. We talked about You Don't Know Piss, the urinalysis deep dive. We also talked about
Did you really title it that?
Yeah, of course.
You Don't Know Piss. Love that.
We also heard about some ophthalmologic emergencies. We heard about some orthopedic radiograph interpretations, which were really good. You know, those always, freak me out. Whitney Johnson always gives us something to look forward to on there. And then we heard from Mike Weinstock as well, where he walked us through his, if it's not in the differential, it won't be in the diagnosis.
Love that talk.
Yeah, and then we had some fun with cases, but it was a great time. It was in Vegas, so I'm a little Vegased out. Every time I go there, I feel like it's a one-time per few months type thing.
It really wears you out. Very sobering experience.
Yeah, so we got to keep doing this because I got to get paid. I lost all my money on the roulette table.
Gosh, okay.
So let's jump in.
All right.
If you're joining us again for the first time from the UCA, please like, subscribe, and follow us below. We do these every other month for urgent care, so they're free, they're really fun, and feel free to jump into the chat. Be vocal. We have someone watching for questions, and we try to keep this pretty interactive.
And we will do our best to also address your questions live, so please feel free to ask questions. We'll make comments when we can. Hopefully we know the answer.
Yeah.
All right. So for our faculty tonight, the show, we've got Sean Nort, we've got Mel Herbert. We also Mel Herbert is here.
That was his only fan.
Mel Herbert's fan, Mel Herbert. And we've got Swami joining us as well. And then, of course, virtually, we have our urgent care team with Mike and Geeta. All right. So, jumping into our next segment.
Yeah, let's do it. Our first segment tonight is our images of the evening.
Let's do it.
It was all a dream. It was all a dream.
All right, so welcome to Clinical Image of the Evening. We've got one image for you tonight, and it is this. And what you are seeing, this is a 55-year-old female. She's got a history of diabetes. She takes metformin for that. She is coming in, she's basically had an earache for about 5 days. 5 days ago, she was given some antibiotic drops, and it's just not really getting any better. In fact, it's getting worse, and now you see this on physical exam. We got together with Mike and Geeta, and here's what they had to say about that image.
So, it's interesting to me that most of the stuff we do in the urgent care, whether it's, headaches or chest pain or back pain or upper respiratory infections, most of it is going to be based on our history. But things like the eye or the skin, or specifically the ear, that's very, very physical exam dependent. So the thing in the history that really made me a little bit concerned and caused me to perk up my ears was the fact that the patient has diabetes. Because when I look at this ear and I see what looks like pus inside the ear and maybe even some erythema of the ear, well, it's hard to say a little bit from the picture, but certainly otitis externa is the thing that comes mostly to mind. And sounds like that's what the patient is being treated for the last 5 days with ear drops for what's probably otitis externa. But, always with that diabetic patient, especially with treatment failure, Geeta, it makes me concerned about some other type of entity that should cause us to really become tachycardic when we think about it.
Yeah, I totally agree. I mean, this patient has presented 5 days later with worsening symptoms. She's not getting better on those drops. She's diabetic. So it's going to raise our suspicion from the outset that something bad is happening. We do have to think about, could it have been an otitis media, maybe with a TM that ruptured, and maybe that's the pus that's draining. It's hard to tell from this picture whether that's pus drain is just from the external canal, or is there granulation stuff in there that might make us start going down this train of thought of perhaps this is a more severe otitis externa, like perhaps a malignant otitis externa. And so other questions I would ask would be, we think about this particularly in diabetics or in immunosuppressed people. I would ask questions like, Is the pain worse at night? Or does it seem like, to us, does it seem like there's pain out of proportion? Do you have pain that radiates to your TMJ area? Or do you have a headache? Do you have any weakness or numbness in your face? Because all those things can happen. Because the real fear with malignant otitis externa is that you're going to wind up getting an osteomyelitis in the base of the skull or in the TMJ, and you can get cranial nerve involvement, and it can turn into like a horrible, horrible, horrible thing. And those are things that, unless you're looking for them on a physical exam, that you might not find. So it's important to do a thorough neurologic exam on these patients too. But yeah, I feel like that what we're being led to believe in sort of a boardsmanship kind of way is, if you were reading this question on the boards, the answer that they were probably trying to get you to get to is malignant otitis externa. What do you say?
Well, I wanted to nail you down a little bit on this pus thing, because I've seen patients with otitis media who then rupture their tympanic membrane, and a lot of pus comes out. And sometimes they say there's a pop. Sometimes they have a relief of their discomfort because of all that pressure is now relieved. But a pretty big differentiator from a patient who has something like malignant otitis externa, where the pus is actually coming from the canal itself. Super, super concerning in that way. So to me, it feels like getting the history for that part of it would be important. And then one other question, I typically, if I have pus there, don't go in and irrigate that. I'm also reluctant to push that pus in if it is a ruptured tympanic membrane. How do you deal with trying to get some visualization of that canal when it's just totally filled with pus, Keita?
I mean, sometimes I will try to use a Q-tip and just not, shove it in there, but just try to absorb some of the pus if I can. I do not irrigate these things. I mean, a lot of times with bad otitis externa, let's be real, like the canal's super swollen and you can't even get a speculum in there, and then you just kind of know it's otitis externa. You might have to use a wick or something to get antibiotic drops in if you're just treating with drops. You'll know a lot too if you insert this, just trying to insert the speculum in the ear. If that is exquisitely painful, if the canal itself is really painful, then you have some information that at least there is an externa going on. You might not know what's going on with the TM itself. But in this particular case, where malignant otitis externa has got to be on our radar, I think we're going to have a much lower threshold to start treating with systemic antibiotics. And I think this is probably the time that we start thinking about am I worried enough about this that I'm going to transfer this patient for a more thorough workup? What do you think?
Well, to me, it feels like that's the quintessential question at the bedside of the urgent care is, do we transfer this patient? And the fact is, we have a patient who is diabetic, who has failed outpatient antibiotics, and who has purulence. Now, if we're able to sort of nail that down, that the purulence is probably from a ruptured TM from a otitis media, to me, it feels like all of a sudden way less concerning. In fact, a lot of ways, the treatment for an abscess is incision and drainage. So if it's draining because of a ruptured TM, it's probably going to get better pretty quickly. But if you've had gradually increasing amount of purulence for the last 5 days, if you have a patient, obviously a diabetic patient who has something like tachycardia, hypotension with a soft blood pressure or low blood pressure, or maybe even altered consciousness, vomiting, or something like pain out of proportion, all those things would be an immediate consideration for referral. But even without that, to me, and I hope I'm not being too cautious here, but in the bird's eye view of things, I've got a diabetic patient who's got pus coming out of their ear, and it hasn't improved with 5 days. I mean, certainly 5 days is enough that we can say this is treatment failure.
Yeah, and I think that the standard of treatment really for if you really think something is malignant otitis externa is really to start with intravenous antibiotics, I think, particularly to cover Pseudomonas. So I think, first step's usually going to be Cipro IV and then transition to oral if you feel like things are really under control. But they often do send things like inflammatory markers. They might do an MR, CT, bone scan, some other nuclear kind of scan. They do all sorts of stuff to see if the bone is affected, because that's really the main concern. And if someone has osteomyelitis of the bone, as you know, it's going to be a very prolonged antibiotic course. So this is not a here's your 5 days of Cipro, go home situation. This is more of a we have to make sure that there is no bone involvement, and that really might require a trip to the ER and even a hospital stay.
Yeah, when I think of any transfer or really any management decision, prescription of antibiotics or prescription of any medication, right? You got to think about the risk of benefits. What's the risk of that intervention? And what is the potential consequences of not doing that intervention? So in this situation, I think it was very reasonable 5 days ago, even with the patient having diabetes, right, to start treatment with oral antibiotic drops, right? And the fact is that oral antibiotic drops probably are going to be effective. And I mean, most patients that we see are just going to have that simple otitis externa that hurts a little bit when you move the auricle. Maybe they were swimming or using some Q-tips. You know, they don't have any signs of hemodynamic instability, or, I mean, they wouldn't really have a fever with otitis externa, even with some type of immunosuppression like diabetes. But we're in a pretty different situation now, 5 days later, treatment failure. And I get it. Maybe they should have put a wick in and the antibiotic didn't actually go all the way in. But I'm still sort of thinking like, you know, we are at the point that there's this really, really serious diagnosis that we're thinking about. And really at the bedside of the urgent care, we just don't have those tools that you just talked about a second ago. The imaging tools, some of the laboratory tools, maybe even admission for observation overnight to see if there's progression of symptoms, those types of tools, the ability to do that at the bedside of the urgent care.
Agreed. I'm interested to see what everybody else has to say.
Me too.
All right, guys, so I cannot fool them. It is, in fact, malignant otitis externa that we are seeing in this image. And I completely agree. This is somebody that you are going to want to transfer from urgent care to the emergency department. They're going to need imaging. You want to look for osteomyelitis or any other complications. Doing a good neuro exam is really important in these patients, as you can get facial paralysis. And then think about this in your immunocompromised patients. And sometimes we don't really consider diabetes as one of those big risk factors. But every time I've seen this, it's been in diabetics. So you got to think about it. And remember, just like Gita said, they need IV antibiotics with antibiotics that are going to cover Pseudomonas. All right. So moving on from our image, we're going to go into a new segment called Wound Care Kitchen.
All right, let's do this thing. We are going to do some suturing. It turns out that one of the most important skills that you can have in urgent cares, according to a number of papers that have come out, is the ability to suture. So, Sean, take it away. Show us the first one.
All right, everybody. So if you have somebody that is arterial bleed with a scalp lac, you've tried your direct pressure, things aren't working. This is a suture that many of you are probably familiar with, but if you're not, we're going to do what's called the figure of 8. So I have my 4-0 loaded already. It starts off as a simple interrupted. So I just go here, and I'm going at the proximal part of that wound. So I just take a nice good bite there. Okay, and I get my forceps here, I pull it all the way through, and I'm going to leave my tail kind of short. Okay, I'm going to reload my needle right here with my needle driver. Okay, and then I'm going to cross back over at the distal portion of that wound, another simple interrupted. Okay, so I'm going to take a very similar bite here. I'm coming through the other end right here. Okay, so it's called a figure of 8. I often describe it, it actually looks like an hourglass more to me. So if you see this, because it's nice square edges here. So why do we like this one? It gives you great tensile strength, and I'm just going to do a quick instrument tie here. And you see how that comes? Look at how nice that comes together, right? So I'm just going to have to throw another instrument tie here to tighten that up a little bit. Okay. So as we pull this here, we're going to get this wound, if I can get my tail right there. Yeah, so we can do it. All right, here we go. We're going to do another instrument tie real quick here. So I'm getting my fake skin is kind of hard. It keeps grabbing me there. All right, there we go. So
now, who are you going to use this in? This is a bleeding wound that you're
This is a bleeding wound that I'm going to do. So for all intents and purposes for our time, I'm just going to stop it here. But look at how nice and tight that is, okay? I'm going to get my scissors here and then right there. So I'm going to use it in a bleeding wound. This one has, as I mentioned, great tensile strength, very similar to a mattress, but a whole lot quicker. So that's the person that I'm using this on. So that is the figure of 8 or the hourglass.
All right, let's do the next one. Who's up next? We've got Scotty. What are you doing?
So we're going to go over a vertical mattress suture, not a twin mattress, not a king mattress, not a horizontal mattress, vertical. But first, I'd like to introduce Tom Wolfson. He's playing the part of a concerned patient family member who's videotaping everything that we're doing. Thanks for being up here, Tom. This makes it very realistic.
And we prepped the skin. We got good lidocaine, a good nerve block in there.
Oh,
this
that's a good
person is pain-free.
Excellent.
Absolutely. So one other thing while I'm preparing the needle right here, loading up a new suture, with the figure of 8, you can see that this cross stitch pattern, it's really good for that tensile strength, but not the most cosmetic suture. So at the end of the day, it's really great for repairing like bleeding areas, really cinching down on the skin. But because of that cinching down, you're gonna have some pressure necrosis that could develop, so if you pull too hard, and you're gonna get no wound aversion there. So it's very possible that you could end up with a poor cosmetic outcome, so you're not using that to just like repair willy-nilly. So a vertical suture, vertical mattress suture, the point of this is for a gaping wound, something that has a little bit more gape here, that you're gonna have a high tension on it when you go to repair it. And we know that increasing the tension on the wound is gonna be a huge problem for wound healing. It's gonna increase scar formation, and it also just increases the chance that your sutures are going to fail. So the whole point of the vertical mattress suture is we're gonna basically do 2 lines of sutures, one on top of the other, one deep to the other, in the wound itself to help pull this together, relieve the tension. It's kind of like building the foundation of the rest of the wound closure. So I oftentimes throw this stitch before I finish the rest of the wound repair to get a better approximation. So starting just like before, but instead of coming up nice like Sean did to the edge of the wound, we actually want to start the first throw of this vertical mattress further back, maybe a centimeter from the wound's edge. I'm going to maybe give a little bit more here because, you know, this plasticky skin isn't as great as real skin, so I just don't want it to tear through. But in real life, I might come to about just a centimeter. So we make the first throw nice and deep through, and we're going to come up through the wound. We're going to reload our needle. I'm going to help myself pull through here.
We've chosen the worst pickups in the world, apparently, because neither of you can use them.
Well, I mean, no, the issue is that this guy is really good at handling insults because I'm thick skin. All right, more jokes at 11. Okay, so I'm going to pull it on through. So we see our first stitch here, and then I'm going to come back into the wound, and I'm going to come through on the other side approximately a centimeter on through, but nice and vertical here. So 1, 2.
So you're doing this pretty deep.
Boom.
It's a pretty
deep for this first throw
trying to
here,
get
Mo.
that deeper tissue together.
Exactly.
I would also add that either vertical or horizontal mattress, sometimes I just do that as the center stitch to bring the gaping wound together, and then do simple interrupteds, and I end up taking this one out at the end, but it really helps bring it together for the rest of the repair.
Yeah, absolutely. Like I was saying before, this is like my first stitch that I generally do to pull this wound together, and then, you know, sometimes I do leave it in too, depending on the tension of the wound. But important, when we reload this needle to go back through, we're not going to be going on another side. We have to actually do a reverse throw. So we have to remind ourselves to load it backwards. Okay, so we're going to flip this around. You don't want to use your hands here if you can all avoid it. I'm touching the non-needle part here to just reorient myself because these needle drivers are a little rough. And so I'm going to make a backwards throw now. And I'm going to go in the same exact line that I started last time, except this time I'm going to go a little bit closer to the wound's edge. And so you'll see we'll get 2 nice pieces of suture in this wound space that overlap each other to provide that extra tensile strength. So here we go, we'll use our pickup, do a backwards throw, boom, I'm through. And you know, normally depending on the gapiness, I don't know if that's a word, the width of the wound, you might be able to get away with a single throw at this point. But here, because it's like plastic skin, I'm gonna do it in 2, and you can see I'm coming up and above, boom, pulling it on through. And now the magic of the vertical mattress, now that I'm done and through, you can see there, I don't know if we can get a close-up shot on those 2 lines of suture in the wound, one stacked on top of the other. So that's double the strength. And you can see as I pull it together to tie it, we end up with a little vertical bit here at the end. And that's where it gets its name as the vertical mattress suture. I'm gonna go ahead and just do a quick little hand tie here. We'll pull it on through.
Also, a benefit of this is that you get a little bit of eversion of the wound, which actually in the end is better for cosmetic healing of this.
So you make a little volcano. It's a little volcano edges so that when it fibroses down, scars, it goes just flatter.
I'm purposely leaving this with a little bit less tension, just again so I can highlight for everybody how we have those 2 pieces right there, and that's our goal. So if I were to tie this super tight, you know, like this plastic might rip if I do, under this high tension, but we've got this little vertical line on either side, lets you know that this is a vertical mattress. So when you go to remove this in clinic, you also know what type of suture that you're pulling out. It's under high tension. That's all I got.
So that's for gaping wounds, vertical mattress. You don't necessarily have to do the whole wound like that, but a couple of those might take away some of that tension I like that. So what are you going to do, Britt?
All right, I am going to do a corner stitch.
Oh, this is a good one.
This
so
is a
this
good
is for
one.
that, dog-eared corner laceration, and trying to put interrupteds there. It always comes together weird if you just try interrupted. So this is a good one.
Exactly. So, and I think one of the good things about this is when you have this corner, this isn't necessarily the most well vascularized tissue. And so a lot of times if you kind of just suture through the end of this, it just scabs off, and then it kind of opens up and you might get wound dehiscence. So this will help for a better repair and bring those corners together really nicely. So I'm going to go in just as if I was kind of going to do a simple interrupted. I'm not going to touch the needle when I reload this. Don't do as I do. And then I'm going to pick up here. Now here is the big trick. We are not going to go through. We're not going to pierce through the skin. We're going to keep subcutaneously and go under like that. See that? It didn't go through the top of the skin. It went underneath through the dermis. All right. Then you're going to pull this out. And now you have your one end right here. And you've got through. Again, I didn't pierce through the tip of that. I just kept underneath the skin. And then you're gonna take one more bite on the other side, pull through, and then I'm just gonna show how this comes together. But basically, once you then make your knot, this comes together really nicely. The edges lay flat. You don't get a dog ear kind of skin tag that can develop. And this will make hopefully a better circumstance for this tissue to actually heal and not just scab off in a chunk.
And then the rest of the wound you just close with just simple interrupted.
And the rest of the wound you just close simple interrupted.
Excellent. All right,
Cool.
I think that was fantastic. So I said at the beginning of this that there's some literature that says that this is really important in urgent care. There's one big study that looked at inappropriate transfers to the emergency department. Now, they basically said that about 50% of the inappropriate transfers were lacerations that were simple that should have been able to be done in the urgent care. So if you don't know how to suture, I think you really need to go to a suture lab to learn how to do this, because patients expect that you should be able to do that, and most of the urgent care associations expect that you have basic suturing skills. If it's really complicated, obviously you need somebody else to do it, but these are the kind of stitches that anybody can do with a little practice. This material that you use is really hard to, it just doesn't quite work. So Britt, what else do you suture with? This is fake skin. Do you use bananas or something?
Oh yeah. When I teach, I use fruit all the time. But also you can just go and practice on chicken, pig, any type of fake skin like that. It works great.
Yeah, I find that's a little bit better than this stuff. So the next thing I think we're going to do is a paper review. Am I right? Or am
You
I
are.
right? Thank goodness.
Paper of the month.
With Swami.
This is by Frost and colleagues, amoxicillin versus other antibiotic agents for the treatment of acute otitis media in children, Journal of Pediatrics 2022. The question these guys were trying to figure out is what antibiotics are being used in patients with acute otitis media, and is there a higher failure rate for amoxicillin versus the broader spectrum antibiotics? And I think we've seen a lot of research over the last 2 decades about acute otitis media. A lot of the research is looking at, do all kids even need antibiotics? Many of these are viral. They're going to get better on their own. We've seen a lot of data around the wait and see approach. We've seen data on how long should antibiotics be prescribed if they are prescribed. And what this group is really looking at is, has there been a change in what bugs are actually causing that acute otitis media? And do we need to go broader with the antibiotic we use to cover it? The idea is that with strep pneumo vaccines being fairly well uptaken by kids, is it shifting what kind of bacteria is causing that acute otitis media? Is it all strep pneumo still? Is it something else? And if it is something else, should we be attacking that with a broader spectrum antibiotic? So what they did was they did a 1-year retrospective cohort using a national claims database of kids 6 months to 12 years of age with acute otitis media. And overall, they collected just about 1 million kids with acute otitis media. That's a lot of patients with acute otitis media to look at. And what they did was they kind of parsed it out by what antibiotic did they get. So let's look at the antibiotic choices here. Amox, which is our first-line antibiotic for acute otitis media, was prescribed in about 56% of kids. When we look at Amox plus clavulanic acid, that was about 13%. Ceftonir made up another 20% of those antibiotics. And then lastly, azithromycin. And azithromycin was prescribed in about 9% of kids. So that shows us a little bit of the spectrum of what antibiotics are being used. But were any of these broader spectrum antibiotics actually necessary? So when they looked at their primary outcome, which was failure rate or recurrence of acute otitis media, it sat at about 5.5% total. And when we break that down, it was 2.2% for failure and 3.3% for recurrence. So those are the numbers that we see for failure. When we look across the antibiotics, there was really no difference. It didn't matter whether you got Amox, Amoxiclav, Ceftonir, azithromycin, the rates of failure and the rates of recurrence was the same. So on the face of it, I think what we can conclude is that it doesn't matter which antibiotic you're given for acute otitis media in terms of failure or recurrence. But I think there's some deeper messages to look at as well when we dive into this data. One of the first things that really pops out is that about 90% of the kids in these studies got the antibiotic for a 10-day or more course. Seems a little long. Now, the recommendation for kids under 2 is 10 days of antibiotic, but for older kids, 5 to 7 is more than enough. So why was it that 90% of these kids were getting longer courses than they needed? I think that's a really important question to ask. The other thing is, we don't know why the prescription was for Amox or Amoxiclav or Ceftonir. It wasn't randomized. So something got into the clinician's head and said, we've got to give a broader spectrum antibiotic to this group. Now that might be that they looked at that ear and said, whoa, that looks like a really nasty acute otitis media. Let's give them some Ceftonir. Or more likely it could be, I just think I need to go broader, based on no actual specific criteria. These were kids with uncomplicated acute otitis media, and the guidelines tell us that Amox should be the drug we're using. But we see all of these other drugs, almost half of the antibiotics given were these other medications, and we don't have an answer for why that happened. So what can we take away from this? I think the first question we always have to ask with acute otitis media is, do I think this is a bacterial infection, and does this kid need antibiotics at all? If it is an acute, uncomplicated acute otitis media, we can probably get away with that wait and see approach. Give it a couple of days. If it's not getting better, here's a prescription. You can fill it in 3 days. That's a very reasonable approach. But if we really think it's bacterial, if we really think we need to give antibiotics, we can give Amox, and we can give it for the right duration, which means, yeah, 10 days in those little kids, the ones under 2, but for the older kids, 5 to 7 days is more than enough. So I think this gives us a little bit of some information on what our practice pattern is and maybe where we should be moving.
All right, thanks, Swami. So really excited to hear what you guys thought of that paper. Acute otitis media, all those antibiotics. What's your first reaction?
There's one problem with that paper. There should have been another arm. We all know what that arm is. Nothing. Because it needs nothing, and it's going to have the same outcome. So that's what sort of drives me a bit crazy with these papers. We all know this is viral 99.99% of the time, gets better by itself, so no antimicrobials. If you're giving a whole bunch of these kids antimicrobials, basically you're turning it from ear pain into diarrhea, and you're not actually improving the ear pain. So you're just adding diarrhea.
Yeah, I totally agree. And I also think the thing that's most suspicious, right, is what 95% of people got better, 5% had either that recurrence or they had some adverse thing. To me, that says that 95% of people, regardless of antibiotic choice, right, like 95% of people probably didn't need an antibiotic, period, right? Like if there's really no difference between these, they have some very different microbial coverages, right? Like azithro and like Amox, very different pathogens that they're going to be covering for. What's your prescribing practice, Sean, for acute otitis media?
So I think if you are inclined to give the antibiotics, because I agree with what Mel said, I agree with Swami said, I agree with what you said. I think amoxicillin is the way to go, the shorter course that Swami said. Augmentin or amoxicillin clavulanate is a really good drug that we do not want to lose by overprescribing, right? So if you look at that, and similarly with the ceftenivir, right? So I think if you are going to be inclined, I would do the wait and see, right? Because that empowers the caretaker, the mom, the dad, whoever it is, that, hey, I don't have to come back. It gives them a little peace of mind. And if you follow them out, now if you look at the worldwide literature, not many of those prescriptions get filled. Here in the United States, it's a little bit more, but I think that really is the practice pattern. But have the discussion about this is most likely viral, and I think then you take it on a case-per-case basis.
Absolutely. There's a really good review/editorial paper, JAMA Pediatrics, May 2022, by Helen Frost, that looks at antibiotic prescribing practices for acute otitis media in the U.S. And even though we talk about watch and wait, she describes how 95% of antibiotics prescribed are prescribed on the first visit for acute otitis media. I mean, she's a pediatrician, does this a lot more than I certainly do, but takes it to an extreme, I think, in a good way, and argues in this paper that anyone over the age of 2, we shouldn't even entertain the idea of antibiotics for acute otitis media, not only because we know so much of it is viral now, but we also know that declining rates of strep pneumo from vaccinations, strep pneumo vaccination being available, that there's really not as much pathogenicity from the other bacteria that might be involved. But for me, still under 2, especially under 6 months, I'm definitely prescribing if they meet those severe criteria. Mel, are you still kind of advocating for that too?
I think that's reasonable as long as you're using some logic to this. The vast majority of people don't need anything. And this idea of giving the patients the power really works. If you look in the EMA database, we have a ton of papers. I couldn't even find them all. There's so many of them, which basically says, look, we think this is fine. Most people are going to get better in a couple of days. What you need, this kid needs is Tylenol. But here's a prescription, and fill it in, say, a magic 48 hours if the kid's not getting better. And if you do that, you reduce the amount of antimicrobials you give by a ton, and patients feel very satisfied, particularly here in the US. Not so much in other places. But what we've done for the last 50 years is fed the bears. Every time you had a red ear, we'd give you antimicrobials. And so Mum's like, well, every other time I come, I give antimicrobials. So now we have to unfeed the bears. We've been trying to unfeed the bears for 30 years, but the literature is pretty overwhelming, except in really high-risk cases, there is no efficacy. And they come in because of pain, treat the pain.
Yeah, and I think that's a really great point, and that's something that obviously this paper doesn't address. It's just about the antibiotics, but what are you actually going to do for the patient, for the caregiver that brings that child to your attention? And I find one way of addressing the why I'm not prescribing antibiotics conversation is just really going into a good detail about the analgesia plan. Because that's really what the patient, what the caregiver wants at the end of the day. I want my kid to stop crying, holding their ear, and I also need to be reassured that a little bit of fever is okay. It's actually a healthy response to what's going on. Do you have any tips on what you generally prescribe for analgesia for these folks?
So I agree. So I do like the alternating acetaminophen and ibuprofen. Of course, I'm a toxicologist, so that gives me a little bit of a safety factor, and I will usually dose it in the same milligram, so there's not as difficult for them to do. So it might be a 10 milligram per kilo dose, let's say, in a pediatric patient. But what both of you said is most important, because that's really what they're thinking. They're thinking antibiotics are going to make this pain go away, right? They're not worried about some sequelae. They're not worried about the rare meningitis or some weird stuff. They're like, this kid is crying, they're pulling out their ear, and then just because, like you said, a red ear is not acute otitis media, right, to be disciplined there. But so for me, it's going to be generally acetaminophen or the alternation of acetaminophen, ibuprofen.
Yeah, the day I have a family member come in concerned their kid's going to get Lumiere syndrome, it's all right, I think we've done all this education, guys. We've reached everybody with it.
I've got a question for you. What about putting in local anesthetic? That was a thing that people did for a long time, dripping stuff in the ear, that maybe that would reduce the pain as well?
Yeah, so there is a drug called Aralgin that had a lot of hypersensitivity reactions. It was a topical anesthetic. I haven't seen it used, and I would not recommend that. I think just regular oral analgesia is the way to go. You're going to cause decreased hearing, holding the kid down who's got a painful ear, now putting stuff in there. I think it's not going to go a whole long way when really these are pretty self-limiting over time, and it is pain control, and then everybody gets on with their life.
Yeah, one of the things I do in my practice is first, if you look at the literature about how we prescribe weight-based medications to children, we're wrong so often. I guess basic multiplication eludes us sometimes, and it certainly, of course, we got multiple different concentrations of drugs and maybe an inaccurate rate could be a problem. So even though ibuprofen, acetaminophen, over-the-counter medications, I actually write down to the milliliter what dose should be administered to the patient by the caregiver. It's a young child, just to save everyone literally some headache and earache, as well as make sure that we're not overdosing, we're not underdosing, and the parents can like kind of just follow the plan here.
That is a great practice. I'll tell you, the pharmacist in me, most of your electronic health record, you can, even if you're not as good doing the math, you could start a prescription, do a milligram per kilo dose. It will give you that dose. Now you want to round it up and be reasonable, right? You don't want to say like 5.75 milliliters, right? You might say 6 or round it down to 5. But that is the safest practice to do because these are fairly safe medications, or very safe medications, I should say. But tenfold errors, particularly in acetaminophen, can be a problem.
Yeah, and one thing for those out there who might be maybe a little bit less experienced prescribing liquid medications to children, just remember a shot of whiskey is 44 milliliters. So if that's like a pretty good, I'm sure most people have encountered a shot of alcohol before, a good volume to remember how much that amount of milliliters is. So when you have someone really tiny, is this a reasonable dose to like pull up and for a small child to have?
Well, it really works too for analgesia. A shot of whiskey in a 2-year-old. Damn, that's good.
Where's that RCT on whiskey on the gums versus, we got to get that going. Any other closing thoughts on the paper? I think we pretty much all agree.
I just think you need to emphasize the stooling. Yeah, you can take those antibiotics, but the kid's going to poo everywhere. Do you want those? They're going to poo everywhere. You're going to have to. They're pooing everywhere. One in 4 kids given Augmentin will poo their head off. A lot of poo.
Yeah. 1 in 4, 95% get better regardless of the antibiotic you choose. I think it's a pretty simple decision. Well, anyways, that's our paper of the month. We got our final segment of the evening coming up. We're going to be doing a board certified case that might help you with some board review. Let's get into it.
Too oaky. Awful. Lame. What are you looking at? Too piney. Don't like it. Boring. I can't see. Too woody. Bollocks. Boring. I said I can't see. Not woody enough. Absolutely awful. Boo! Ow! Ow!
All right, we have got a case, a real case, and I have some idiots here that are going to tell us, physicians here, they're going to tell us how to run this case. So I've got a slide here, let me go through this. So this is a really common presentation. There is no tricks here. This is just bread and butter urgent care stuff. 24-year-old male comes in, he's had about 24 hours of nausea and vomiting and a little bit of diarrhea. Said he vomited about 5 times this morning. And he's got a little bit of upper abdominal pain. So Scott, you're really good at the oral board review thing. Tell me what you're going to do with this guy.
First thing I want to do is get a set of vital signs.
Yep, normal.
Normal, perfect. And then walk in the room and see how he looks. Like when he's sitting in the bed, does he look comfortable? Is he in incredible amount of pain?
He looks pretty good, actually. Your gestalt is this is not a sick person, and he's just maybe mildly uncomfortable. So you want to examine him. The exam is basically normal. He's got a little bit of tenderness, kind of all over, maybe a little bit more in the upper abdomen than anywhere else. So, Sean, is there anything that you want to do with this guy? Again, no tricks. This guy looks good. He's just got a bit of vague pain. What else do you want to know?
I want to know if he's had this before. He's a young male. Is this inflammatory bowel disease, right? Is there blood? That's going to be a big branch point for me. And where you're saying he's just not really tender anywhere, but is it left lower quadrant? Could it be diverticulitis? Again, fairly young guy. Diarrhea? Could be appendicitis, right? Sometimes you'll see that with appendicitis. So I think really focusing on the exam, getting the history, and just going from there and just making sure there's nothing subtle about this case that I might miss closing down too early.
Okay. So he did say that he had 1 episode of some blood in his poop. It wasn't much. It was kind of mixed in there. But the other stooling was just poopy without any blood. He doesn't localize anywhere. He's never really had this before. And he's otherwise healthy. He's got no past medical history. This is a healthy guy playing hoops yesterday, and now he thinks it was sort of the chicken that he had last night from Chick-fil-A, somewhere like that. And he's convinced that he's okay, but he just wanted to get checked. So, Britt, is there anything else you want to do for this guy?
I think a couple things on history too. You said healthy, but has he had surgery? Does he have his appendix?
He has his appendix.
Has he traveled at all?
Nope.
Or did he just go to Chick-fil-A?
Just
or
Chick-fil-A.
wherever he said he was going.
He traveled to the valley, the San Fernando Valley.
And then you said normal vitals. Does that include a temperature?
Yes, he had a temperature which was oral and normal,
Okay.
afebrile. I got a question for Scott. So a lot of this happens all the time, right? You got non-specific abdominal pain. Somebody looks pretty good, and you're like, should I do something, nothing, follow up? What about CBC? If you are in a place that has CBC, it's almost impossible for you not to send one. It's just become like pain, belly, CBC. What's the evidence for using a CBC in this?
Yeah, that's a great question, Mel. I think, like you said, it's pretty hard to avoid, depending if you have access to it, getting a CBC or some inflammatory markers. And the thought, at least before the rise of CT abundance everywhere, ultrasound access everywhere, or in a setting where you don't have those things, could this be helpful in helping us risk stratify this person that has like maybe a kind of concerning exam, maybe a kind of concerning history for appendicitis into a high-risk category? Is this somebody that we should refer to the emergency department? Can we make that diagnosis? The evidence is pretty terrible for looking at a CBC alone. And I would probably generalize that to say all inflammatory markers. So most of this research came out in like the late 1990s in the Journal of American Surgery in 99, 98, talking about all of these different aspects of the CBC that I never calculate, like the neutrophil to lymphocyte ratio. Like they were trying everything to find a marker that's stuck with appendicitis. And there's also studies in the past 2 or 3 years coming out from other parts of the world. There's a few that are actually out of Africa that are kind of interesting, looking at how high is the leukocytosis and how big is the appendix when they look on ultrasound. So maybe the thought is like, if it's really, really high at that extreme, maybe there's a higher chance that there is actually appendicitis, because we know that generally at some point when you have true appendicitis, you're going to mount a leukocyte response. You're going to have leukocytosis. But the problem is that the sensitivity is only in the 80s, the specificity is in the 50s. This is a really poor quality test to help you make that initial decision. And kind of the way it was explained to me in training was that the white blood cell count is the last reprieve for the intellectually destitute. It's like if you're trying to base your medical decision making on the white blood cell count, you're going to have a bad time. The patient's going to have a bad time, I guess more appropriately, right? But there are a few things that we could take away from the CBC. If the CBC is greater than 15, there is a higher chance that sensitivity goes up. The specificity still stays pretty poor. But, like, especially in my practice, if I get like a CBC that's like 18, 19, I start to really be concerned that there's something else going on. Like I know it's not a great slam dunk test. You can get that high with like influenza, with gastroenteritis, it's viral, but it's a moment of pause for me. If it's less than 10, there is a little bit of relief that's given to you. Again, you can't hang your hat on it. I think it's like trying to catch a picture of a speeding bullet with a Polaroid camera. The patient comes in too early, you might miss that leukocytosis because they haven't mounted the response yet, but in 24 hours, they'll have one when they're sitting at home with their ruptured appy just hanging out. So long answer to your question, well, evidence supports that, yeah, you're going to get one. It's not going to be that helpful, but I don't think there's possible to take a patient to the OR in any hospital in the United States without a CBC at this point for appendicitis.
It's super frustrating because one of the biggest studies ever done was at Oliver UCLA, where Britt and I trained, where every second patient has appendicitis. And they did this huge study, I think it was 2,000 patients over a weekend. Well, it was a little longer than that. And it showed that it was completely useless. And yet, as soon as it got published, whenever you called the surgeon to come down to see a kid who clearly had appendicitis, their first thing there is, what's the white count? This is something that's so stuck in our heads. It is a terrible test. If you use it, don't make poor decisions on it. So I'm going to tell you what happened, because this is actually a real case. And the physician that saw this person said, look, I don't really know what's going on here. Maybe it's infectious diarrhea. You look pretty good. Have some levofloxacin and follow up with your primary care doc. So, Britt, what would you say to somebody that you're sending home with non-specific abdominal pain about follow-up and discharge instructions? Because that's the most important part.
I think discharge instructions, like, really clear, not like, see your doctor if things get worse, or like, return to urgent care or an ER in 2 days if not feeling better. Like, you need, especially when you have this, you don't know, and it's okay, you can be honest, like, hey, I think this is probably just some viral gastro, but there was some blood, and I'm not really sure, your exam isn't all that impressive, but like Scott said, you might just be finding, something terrible at the very beginning of its course, and it just really hasn't presented itself yet to be clearly obvious that something horrific or not terrible at all is happening in this person's abdomen. So I think, not just the click, see your doctor in 2 days, but if things are getting worse, specifically, if you start to develop a fever, he had blood in his stool, but if we're having found diarrhea with blood every time. He's vomiting, it sounds like, a bit, and having diarrhea. A big thing for me, even if it's just viral gastroenteritis, is making sure that they can keep up with hydration. If they're going from both ends, sometimes that can be challenging. Oral hydration really is key here, and I don't think, at least from what you're describing, that I need to stick an IV in this guy and do IV fluids, because really if he can tolerate PO to a certain extent, then he's going to hydrate just fine. But if this diarrhea and vomiting really starts to become profuse and he's, vomiting and having diarrhea every 30 minutes, then he's probably not going to be able to keep up with his hydration. So that would be a key of returning even to urgent care or to an emergency department. And then I think, especially with the pain being kind of vague, is it just crampy before he has an episode of diarrhea, or is it kind of periumbilical and about to localize to the right lower quadrant or the left lower quadrant? And so if the pain moves, becomes worse, like specifics on that, I think is really important in terms of your discharge instructions.
All right, I think that's great. So he says just before he leaves, that's all great, doc, that's fine, but I do have I'm a little bit uncomfortable. So what about outpatient analgesia? Well person, non-specific abdominal pain, good follow-up instructions, but he wants a little something for pain. What can he take?
So the things that he can take for pain, I think, are acetaminophen would be a great one. And I think with acetaminophen, people do too little, too frequent. So a good dose is 15 milligrams per kilo, which is 1,000 milligrams. And I think if you do 1,000 milligrams every 8 hours as needed is a good dose. People who do 650, that usually is too low in an adult, particularly if they're 80 kilos or more. So I think that's one thing. We have to worry if this is truly bloody diarrhea, which is probably what's pushing them to use the levofloxacin, right, for an infectious diarrhea with blood. I would not use hydrocodone or oxycodone because we do not want to give them anything that's going to slow down their GI tract. Like, we're not going to give them loperamide with this because we worry about that with bloody diarrhea. So if you say, well, he's very uncomfortable, the hydrocodone, oxycodone, that's going to slow down his GI tract. Similarly, what I will do if I'm not doing imaging and I'm like, hey, I'm not sure, but hey, we're all on the same page here, particularly if they waited a long time. If your urgent care is super busy and they're like, I waited 15 hours or whatever, I'm not going back there. I'm just going to keep taking my hydrocodone for whatever. So I might give them, let's say in another circumstance, a very short course of hydrocodone, maybe 4 tablets or something to get them over that hump. But I don't want to give them, a 5-day supply where they're not going to come until they're perfed. Let's say that if this was an appendicitis or a complicated inflammatory bowel disease. I think ibuprofen too would be easy enough, right? Just make them comfortable.
Okay, that's great. So we had this 24-year-old guy, he had vague abdominal pain, he didn't look too sick. He was sent home with good outpatient instructions. And this was actually reviewed by a group of experts and a group of lawyers, and they agreed that what was done in this case was fine. This is the kind of patient you see 1 million times a day. So of course he comes back. He comes back about 8 hours later and says, I don't feel too good. I have not stopped vomiting. The diarrhea has continued and there's more blood in it. And you walk in the room and you do a gestalt, as Scott would do for his oral boards, and your gestalt is, uh-oh, he looks terrible. He looks ashen, terrible. What do we do now?
It's a great question. I mean, it was funny when we were talking, when you alluded to he's had 1 episode of bloody diarrhea, like a key question is like, was that the last stool that you had? Or was that some random time after wiping before, right? Because it's not a good look to have somebody about to start having truly like dysentery at this point and then to send them out. Honestly, like I'm working the urgent care, I have somebody in front of me that looks awful, like I'm gonna repeat vital signs. If he's hypotensive, I'm gonna try to support him by giving some IV fluids. While I'm activating 911, I'm transferring this person to a higher level of care. Because like all the things on this differential, I don't know if at this point he's got a necrotic piece of bowel from like a closed loop SBO or like an LBO or something else that's going on there that needs to be healed with steel, needs to go to the OR. So I'm just getting that patient out of there as quickly as possible while reasonably treating his pain and supporting his vital signs.
Yeah, that seems reasonable. Your gestalt is, we've missed something here, and it's time to take him to the hospital, get the CT scan, get everything going. Unfortunately, this gentleman died. He returned, and very soon after representing, he actually went into cardiac arrest and died. And
wow.
this is obviously a big deal, and nobody saw that coming. And on autopsy, he had basically infarcted all his bowel. He had a prothrombotic condition that hadn't been diagnosed before. And this was the first presentation, devastating presentation, where he basically just infarcted everything. But again, this
never
was
had a blood clot before or
Nope.
anything? Wow.
no history before. So there's something about this is weird. We will never know the full story, but you know, on autopsy, it's sort of everything's dead and we don't know why. And we'll probably never know why this particular person, 1 in a million. Again, when the experts reviewed it, they said there was really nothing done wrong here. This is just, unfortunately, if you practice medicine, every now and then you're going to get hit by a lightning bolt. And this person got hit by a lightning bolt, and so did the people that looked after him. It's actually, Britt, if there's a book next to you there, this is actually one of Mike Weinstock's bounce backs cases, which is a really good series. So I just took that from there because I wanted to present what happens all the time. Vague abdominal pain, you don't think it's anything, good outpatient instructions, the vast majority of people get better, some come back with appendicitis. This is a 1 in a million, so don't go like, oh my God, I got to CAT scan all of these people and I got to admit them all. That's not the point. The point is good instructions. Most of these patients do well. So a couple of questions that have come up. Are you ready? So the first one is about this slowing the GI tract. So this used to be a big thing. If somebody had infectious diarrhea, don't slow the GI tract, they've got to poop it out. My understanding was, and this person, I think this was Vincent that asked this question, was if you've got infectious diarrhea, it's okay to give Lamotril and other stuff as long as you're also giving antimicrobials. Do we know what the literature is saying on this today?
That is true, right? So there is some concern that you're going to prolong the illness, right, if you have this. I think that it's safe as long as you have good follow-up, and I would do both. So if you are going to give them an antimotil, because if they're really stooling them, right, you're not going to just leave them at home, right, until they come in and have to be rehydrated. But that being said, if they can keep up with their POs, I think it's fine to just say, just do supportive care with that. But I agree, you can, but I would have that combination therapy.
And in peds, we used to worry about it, that a lot of the antimicrobials, if you had the right bug, increased production of Shiga toxin and maybe increased HUS. So the American College of Pediatrics sort of gone back and forth a number of times, like never ever give kids antibiotics, just let them poop it out, because there was this concern. I don't know, frankly, where we are right now. Do you know where the American Academy of Pediatrics lies on bloody diarrhea in kids now? They were definitely against it. Any ideas? I don't know.
But I think just like the big concern is like you could inadvertently make things worse by someone with like HUS, right? Somebody who has like a Shiga toxin producing E. coli infection, OH75215, whatever that number is, right?
0.375.
0157.
And so that's just the classical teaching that I'm aware of.
Well, while we looked that up, we've got another question, which was about otitis media in kids less than 2. The recurrence rate, I think, was quoted at 3%, and this doc, it's Neil, was asking, does that seem right? Is that really low, that number? Where does that come from? What do you guys think?
In the paper that Swami had, that's what we're talking about, right? Yeah, and so like what I think is interesting about that paper, right, it's a retrospective chart review that all these diagnoses are pulled on final billing code, right? And so like we don't, that, you know, recurrence rate of 3.3%, we're getting pulled from like this pretty like poor data source, right? It's great for looking at stuff like how many antibiotics are being prescribed, what is everyone's practices, but at the end of the day, like we don't actually know what that in my opinion, like was that recurrence rate because the second time they bounced back, they were just written into the chart by the next provider, like, oh, it's still acute otitis media. Like we don't have any information about the time lapse between those things and things of that nature. So I think that's, I don't know, from my understanding of the literature, like it seems low, but it seems like that's appropriately low.
So there was like 1 million patients, right?
Yeah.
And it shows how so many did well. So that just tells you most of them did not have bacterial acute otitis media. You did not have inter-rater reliability where you have 3 clinicians go in and all agree and say they all agree that this is acute otitis media, and you can do a kappa and say the kappa is great. And then you move forward and say, okay, of those. So I think you have to be really careful, Mel, looking at that and saying 3%, because I agree with the person watching that is probably a low number for true bacterial acute otitis media, particularly if it's a kid who's going to be recurrently having issues.
Right. I think the key is that we can't actually tell which ones were bacterial, which ones were viral. And like we said earlier, if you don't do anything to most of these kids, they're just going to get better no matter what.
Great. I just did a quick review of the literature on antibiotics for kids with dysentery, basically, and studies from Kenya and other places saying most of the time don't do anything, just leave them alone. If they look sick, if they have significant underlying disease like sickle cell disease, there is sort of a group of experts that say, yeah, you should probably treat those kids, and you probably even should admit them for 24 hours just to watch them to see which way they're going to go. So great question. Well, that's it. I want to thank you guys for doing this case. Please don't take away from this that you do need to do lots of tests. The important thing is your discharge instructions. They should be time specific, location specific, and symptom specific about here's the things you look for. So Britt did a great job there. A little analgesia, that's why they came. My belly hurts and I'm pooping. If you could help me with those two, I'm out of here real fast. So thank you for everybody for playing tonight. I thought this was fantastic. Any dying words? Not dying words, that's a bad word. Ending words.
We're not dying.
Yeah, I think I always struggle with cases like this 1 in a million case, right?
Yep.
Because like we should never practice, we should practice medicine with great respect for the pathology that patients come in with, but not fear. It's easy to like see this outcome and the next time you see somebody who has gastroenteritis be like freaking out, staring up at the ceiling at night. Even knowing the outcome of that case, there's nothing I would have done differently on that initial visit. And it's sometimes possible to totally play the game perfectly and still lose in the same way that you could totally mess everything up and still end up at the right answer. So we just have to have like great respect for the patients that come in.
And what I said and what I do a lot is just bring them back. You said that. So if you're really nervous, bring them back 12 hours, 24 hours or something like that, right? And if you want to be concerned and say, hey, am I going to be masking a bad infection or something, hold off on the antibiotics, right? And then just bring them back. So I think that that's another way, rather than going, hey, I'm just going to image everybody looking for this weird 1 in a million prothrombotic condition that you'll never see, any of us are going to probably ever see.
Yeah, and I mean, we joke about the donut of truth and the CT scanner, but really, I mean, you don't, for a 24-year-old, otherwise healthy, even if I was seeing this person in the emergency department and did have all the MRIs and CT scans in the world, I still wouldn't have scanned him from the beginning. It didn't sound like it was indicated at all. So, think about your differential, remember to do a really good physical exam, trust your gestalt, and it sounds like it was just going to be a bad outcome no matter what you did.
Yep. The best diagnostic test for abdominal pain for thousands of years has been time.
That's right.
When somebody presents vaguely, time is going to be your friend, and bringing them back, we used to do that at all the time. I don't think there's anything, but it's probably going to be appendicitis because it's always appendicitis. See you in 12 hours and let's see what you look like. So great points. Thanks everybody. Thanks for watching. We'll get the edited version up on the site soon, but see you in 2 months. When's the next one?
In a month.
In a month? Okay. The urgent care's one in 2 months?
Urgent care's in 2 months, emergency medicine in 1 month.
In a month. And you can check it on the website. We'll be sending you emails. Out.